So again, thank you for being here. I'm Steve Dobshaw. I'm the director of the Center of Innovation in Portland, Oregon, the Center to Improve Veteran Involvement in Care, otherwise known as CIVIC. And today I'm going to be speaking about a demonstration project that's funded by the Office of Mental Health and Suicide Prevention that's allowing us to develop and evaluate a training program for primary care teams to discuss mean safety with veterans during primary care visits. And I don't have any relevant disclosures beyond that. So what is lethal mean safety? Actually referred to as mean safety more typically because it turns out that patients prefer that term. It might be a little bit more useful. But it's basically referring to reducing an individual's suicide risk by reducing or slowing access to methods for suicide. And it's based on a number of key concepts. The first being that serious suicidal ideation is often transient. And in addition, people who are having serious suicidal thoughts are often quite ambivalent. And the idea is that if you can move people past this period of time, which is often brief, that they may naturally move into a safer place. We also know that many attempts occur with little planning during a crisis, and again, if you can get them through that crisis, it can make a difference. There's some evidence that substitution of method of suicide usually doesn't occur, although I think more research needs to be done in that area. And finally, and relevant for this talk and for our training program, which is really focused on firearm safety, access to firearms is an important risk factor for suicide. So this is a slide from a study by Thomas Simon published in 1981. Or 91, he interviewed 82 patients who were admitted to a psychiatric inpatient unit shortly after their admission for a suicide attempt, and inquired about how much time elapsed between when they started to have very serious suicidal ideation and when they actually made the attempt. And what you can see from the slide is that about 50% or half of that group had that serious ideation for only 10 minutes or less. And actually about 2/3 of that group had it for 5 minutes or less. So again, that movement from a very serious thought or set of thoughts to the actual attempt can be, it can take place in a very brief period of time. So mean safety is all about trying to nudge people to get through that time. So I mentioned that firearms is a focus of our training. Give a little bit of background on that. We know that veterans are more likely to own firearms than civilians. Probably about half of veterans own firearms compared to 20-25% in the general population. Veterans are more likely to die by firearm suicide than in the general population, including among women veterans. And several larger epidemiologic studies suggest that safe firearm storage practices are associated with lower suicide risks. We also know that public health interventions or legislative interventions that impact access to firearms is definitely associated with suicide rates as well. There's a little bit of evidence, and not a lot at this time, about mean safety interventions having potential to change storage practices. I always forget that Rouhani Rahbar in 2016 published an excellent review of 7 mean safety interventions, the clinical trials, and found that, and most of these were counseling interventions, and found that counseling interventions show some promise, especially if you combine it with giving people a free locking device, such as a cable lock, for leading to actual changes in patient behaviors or individual behaviors around firearm storage. But again, the studies, it's a small set of studies. Several of them were done with pediatric populations, not with veterans. So there's really a lot to be learned about effectiveness of mean safety at this time. And finally, as far as background go, we know that veterans often store their firearms in an unsafe manner. This is a graph from Joe Simonetti who did a survey study of 451 veterans, finding that about a third of the group had at least one firearm at home that was both loaded and unlocked, which is considered to be very unsafe. And if you look at the bottom bar, only about a quarter of the group had all of their firearms both locked and unloaded. And that's kind of the basic universal standard that I think we think of when we think about firearm safety. You can do more than that, and sometimes you absolutely have to do more than that, but that's the starting place. So how does this impact primary care? Well, we know that half of individuals who die by suicide see primary care teams in the month prior to death. This is true within the VA setting as well. And most of those patients do not see mental health clinicians. So there's an opportunity in primary care to intervene. And importantly, routine screening now for depression, PTSD, and now also suicidal ideation is identifying people at risk, and the primary care teams would like some help with knowing how to respond. So we designed this approach. It's called the Means Safety Messaging Approach. And again, we're really piloting this idea, but it's really intended to be a brief conversation specifically designed for primary care. So means safety counseling interventions have been around for a while. These are typically done in specialty mental health settings by mental health specialists for patients with known suicidal ideation. We're trying to move this conversation upstream to people who may or may not have suicidal thoughts, but probably are at risk. So we've kind of targeted, and we're teaching the primary care teams about if you have a patient who screens positive for depression or PTSD, but even if they don't have suicidal thoughts, that's actually a great time to have this kind of a discussion. And this idea actually comes from the Harvard Means Matter campaign, who shared a little bit of consultation with us. But it's really a shift in the model from negotiating with a patient about their firearms and motivation interview more to providing brief advice and information. And we do know that some brief health messaging interventions can make a difference. So, for example, screening brief intervention referral and treatment expert models that have been used for risky drinking, or the 5A model for smoking cessation. So not a huge literature on the effectiveness of those approaches, but there's some. So our project really has two phases. The first is to use an iterative design process, working with veterans and clinical teams to adapt and refine the intervention for use with at-risk veterans in primary care. And in phase two, we're developing a PACT training program, piloting that program, doing some preliminary evaluation, and also putting together a training manual and creating some supplemental materials. Right now, I'm going to talk about just phase one results, which is really qualitative results from the first one. So in phase one, we did 4 listening sessions with 4 clinics, 4 primary care clinics. It was over 100 individuals participating. Probably at least half the group was nurses, but definitely providers, MSAs, other staff. We also conducted 4 listening sessions with 4 veteran groups. We won a fairly large group in the community, a military appreciation community committee that's located in Vancouver, Washington, across the river, but also several groups that were connected to the VA Portland healthcare system. And as well, we followed up with some individual interviews. And in these meetings, we explored overall attitudes towards conducting means safety discussions in primary care, and also presented test messages in various places at various times, and try to get some ideas on specific messaging that might be helpful. And then for our analysis, we reviewed transcripts and meeting notes and analyzed them using a modified grounded theory approach. So what did we learn? I think the most interesting finding is that there were a bunch of common themes that independently came from both the veterans and the primary care teams. So the first one is that means safety discussions are within the purview of primary care. The primary care teams, although sometimes uncomfortable, maybe a few outliers in the group who weren't too happy with the concept, but overall there was a really strong message that they thought this was important and part of their job. And the veterans also felt this. There really were no questions about that, especially if the rationale can be provided, but I'll come back to that. In addition, both groups felt that a team approach should be used, and for slightly different reasons. So this is a quote from a primary care provider, but this is where a team effort really has to come in. There's so much other stuff being piled on a primary care provider, they feel by themselves and they may feel overwhelmed. So competing demands on providers, lots and lots of things they have to do. The veterans' message was a little bit more along the lines of this. You'll see the nurse practitioner a lot more, so they are more trustworthy. I feel like that could also be a good place for peer support specialists, having the rapport without having met them because you both speak jive. So veterans feeling like they may have connections with people that they can find those discussions more trustworthy. Both groups identified a potential to link these discussions with whole health or preventive care. And certainly in the pediatrics world, it's becoming, if not already, a standard of care to talk about firearm safety in homes kind of routinely as far as a preventive approach, but these groups recognize that there may be value to tying it with our new whole health initiative and making more of a universal message, not really selecting particular people to give the message to. Additional themes, direct questioning about ownership may not be the best approach. So several groups told us, if you ask us, and especially if we don't know you, we're not going to tell you the truth. Because of all the stigma and concern these days, that's a real issue. I think the flip side is if you really know a patient well, you may be able to just ask them directly, do you own a firearm? So the first veteran said, I would say the other reason why someone is not going to be happy about that question is because then their next thought is, this mother effer going to take my gun? And that's very, very valid. I mean, especially if you're already having a lot of fears and instability issues. Another veteran said, one of the questions I think, because I've been asked by my provider if I have firearms, and because I'm a supporter of the Second Amendment, I didn't give him what he wanted. Maybe a little softer approach to ultimately lead up to it. What can we do about pharmaceuticals? What can we do about firearms? Legal and regulatory concerns were quite common among both the clinical teams and the veterans. If I own, this is from a PAC member, a patient-aligned care team member. If I own firearms, what's the process? Are they going to want to take my firearms? I mean, there's no information out there for any of the veterans as to what they, meaning the VA, are actually going to do. What's the VA's policy on the weapons if you find out somebody with PTSD does have those? So to summarize a little bit what would help, kind of extracting from this information, it's very clear that authenticity and personalized conversation are critical. This is not a time to be looking down at a computerized template. I've been advising the primary care teams, think of this as the way you might take a sexual history. You know, it's a sensitive topic for many people. You need to provide a context for discussion. Why are you asking about this? And you need to offer information and options and acknowledge autonomy. The veteran is in the driver's seat, especially if this is someone who may not have suicidal thoughts. I think it really needs to be framed that way. A focus on safety and well-being seems to work. And then just the PAC teams are wanting more education and supplementary materials. So I handed out this handout. I won't have time to walk through. This is a pocket card. Actually, I didn't hand it out, but you did. That we prepared for primary care teams. It's not the complete version, but it's very close. It's got a model for the GROW model for thinking about how you might have these discussions, and it's got what some of the teams asked for, which are some scripts, some types of language, and these have all been vetted with the veteran groups that we've worked with. So that's one thing that's being produced. We also have a brochure that OMHSP is currently working on putting together, and these will probably both be nationally distributed. I listed some useful resources. The only thing I'll mention, because there's no time, is that there is an online course available now through TMS training. Many of you may have been required to take it. It's an excellent course. We go into much more detail about this. It's really designed for clinicians. And I just want to acknowledge some of the various members partners that have been involved in this project. Maybe highlight the National Shooting Sports Foundation, who's now partnering with the Office of Mental Health and Suicide Prevention, gave us input into some of these materials, as well as our training program. They've been a great group to work with. And that's it.